Hi, my name is Kyle Doyle. Today I'll be doing x-ray setups of the shoulder. These will be done at an SID of 40, all standing, and we'll be using a cassette that is 12 by 10. So I have my cassette here hanging up against the wall, my right side marker here for my right shoulder that I'll be working on. So to start, we'll be doing the A to P internal rotation. So the patients will be standing with their back up against the cassette. Their arm will be internally rotated with the back of the hand resting against the thigh. Our central ray will be directed through the coracoid process, and this will give us a view of the greater and lesser tuberosities, the glenoid fossa, and the scapula. Next, we'll be doing the A to P external rotation. So the patient's back will again be up against the cassette. Their arm will be externally rotated and slightly abducted. Again, our central ray will be directed through our coracoid process, and then this will give us a view of the greater and lesser tuberosities almost superimposed over each other, and we'll be able to see the bicipital groove in between them, as well as an A to P view of the humerus, oblique view of the glenoid fossa, the distal clavicle, as well as the scapula behind them. Next, the baby arm. So patient's back will be up against the cassette. The arm will be abducted to 90 degrees, elbow will be flexed to 90 degrees, and the shoulder will be externally rotated to 90 degrees. Our central ray will be directed through the coracoid process again, and this will give us an ADP projection of the shoulder joint and the AC joint. Those three views are for more chronic injury or pain. These next three views are for traumatic pain, traumatic injury. So first we'll be doing the A to P neutral. So this, again, the patient's back will be flat against the cassette. The arm will just be rested, relaxed, with the palm at the thigh, resting on the thigh. Our central ray will be directed through our coracoid process again, and this will give us an A to P projection of the shoulder joint, the AC joint, and the proximal humerus, distal clavicle, and the scapula behind them. Next, we'll have the AP Grashy view. So the patient will stand with their back facing the cassette at a 30-degree angle. The central ray will be directed perpendicular to the arm just below the head of the humerus and the little divot that you can feel. And this will give us a lateral view of the glenohumeral joint. Next we have the scapular Y. So this time the patient will be facing the cassette. Their shoulder will be up against the cassette with their body at about a 60-degree angle. The scapula should be about parallel to the cassette, and this will give us an axillary view of the scapula along with the coracoid and acromion processes. Next we have the A to P clavicle. So the patient's back will be up against the cassette, with the arms just relaxed at the side. The central ray will be directed through the midline of the clavicle, and this will give us an A to P projection of the clavicle. Next is the A to P tilt. So the patient will be set up in the same position with their back against the cassette. This time the central ray will be directed through the midline of the clavicle, but at a 10 to 20 degree cephalad angle, so that we get a projection of the clavicle where there is not superimposition of the ribs or the scapula. And then lastly, we have our A to P AC joint views. So these are going to be the same setup for both. One first will be not weighted, the second one will be weighted. So the patient's back will again be up against the cassette. Our central ray will be directed through the AC joint, like so. And then we will do the same setup again with a 10-pound weight in the 10 to 20-pound weight in the patient's hand. So back against the cassette, and central ray directed through the AC joint. And these will give us an A to P view of the AC joint, and be able to compare with or without weight in the hand.